Welcome back to the King's Podcast, The Wellness Dive with Lackie. I'm your host, Esther Lackie. Today we are joined by Dr. Paul Macnamara, consultant orthopedic surgeon at King's. He'll be taking a deep dive into enhanced recovery after knee and hip replacement. Thank you, Dr. Paul.
Thank you, Esther. It's delightful to be here.
So we here, we know what you do, but our viewers don't.
Mm-hmm.
Just recap on what you specialize in.
Okay, so I'm a consultant in hip and knee joint replacement of the lower limb. And this is a very specialized area where you just perfect your technique in terms of just purely in the hip and purely in the knee.
Mm-hmm.
I trained in the UK in some high volume centers, some of which were doing maybe 4 or 5 joint replacements a day.
So you just mentioned you specialize in the lower limbs.
Yes, that's correct.
So patients who come to see you, how common do you think these hip and knee problems are, especially here in the Emirates?
Well, it's certainly increasing. I mean, as the populations get older and we're putting a little bit more demand into our hips and knees. I mean, a lot of more middle-aged people like myself probably want to still play five-a-side football, and then they have sort of legacy from their previous lives, when they were doing their sport when they're younger. So certainly the population needing this type of procedure is only going to increase. Mm-hmm. And also the redos of this will increase as well exponentially throughout the world.
Uh-huh, uh-huh. By the procedure you mean hip and knee replacement?
That's correct, yeah.
All right. And what are the common causes for this? I mean, we know age is a big
well, certainly, yes. I mean, that's it. So just being on the planet for long enough, okay, will certainly get you maybe a hip and knee replacement. So I tend to sort of break it down into early, moderate phases and late. And the early ones, let's say everything up to 40 years old, okay? Then we're into sort of the middle age. It varies a lot, okay? Mm-hmm. And certainly, but let's call middle age somewhere between sort of 40 to 60 years old. Mm-hmm. And then 60 to 70, and then plus, you will end up most likely needing a hip or knee replacement. I get patients asking me that a lot. And I said, will I ever need anything like that? I said, well, if you live to 100, almost certainly you will need one joint replaced. So, yeah, I mean, I've done very young patients, hip replacements. I mean, this was from another cause, from, say, trauma. Mm-hmm. But there's also other conditions, for example, like avascular necrosis, where the blood supply of the hip actually goes. And there are multiple causes of that, one of which being steroids and all sorts of drugs and sickle cell and things. So I can get my patients very young, and by that I mean even in the 20s or 30s. Wow. And the same with the knee. Maybe they've been doing something like a rugby or something like that, which is a high impact sport, and they've come into trouble with their knee in their early to mid 50s.
Okay. So doctor, before you decide to go ahead with the procedure,
yes,
at what point after seeing your patients do you decide there's no going back with this one?
Yeah, well, that's key to it.
Yeah, okay. This person needs knee replacement or hip replacement.
So that's absolutely key to it. And so we have a set of criteria throughout my training, but generally pain is obviously a big mark of that. And pain that hasn't been controlled by various conservative measures. Okay, so the first one of which would be whether they've tried any anti-inflammatories, any physiotherapy, and have they lost any weight. Weight is certainly a factor for osteoarthritis. No one really can predict how much, but it would certainly alleviate a lot of problems, particularly within the knee, I found, if you could take a few pounds off. And then if you're still struggling with these conservative therapies, and if the knee is in what I call an early to moderate phase, i.e. there does not have bone-on-bone change, and we can still get some handle on the pain, then we might consider an injection. And that's a very kind of subjective thing in terms of what the surgeon uses. Previously, people use steroids, and they can use stem cells, both of which I'm not a great fan of. I do tend to use hyaluronic acid, which is like a sort of heavy gel within the knee.
So what does it do?
Well, it sort of essentially replicates the fluid within the knee. It's got a high molecular weight, and it's basically like the oil within the joint. And it works around about, most of the studies suggest 60% of the time. And sort of anecdotally, it probably works more in the more active patients. So you can do that in the relatively early to moderate phases. It's well known that when it's late, when the bone is on the bone and it's severe pain, and maybe it's waking at night and you've taken lots of painkillers and maybe you've exhausted your physiotherapy, then you're going to probably need a knee or hip replacement.
Wow. Okay. So the patient definitely needs the knee or hip replacement.
Yes.
Take us through the procedure. I can say you brought some of your toys here.
Yes, some of my toys. Yeah. Okay. So first of all, the knee replacement. It might appear like a bony operation, but we always say throughout our training it's actually a soft tissue procedure as well.
Mm-hmm.
Okay, and it probably is as important, if not more important, to get the soft tissues right and the knee balanced. And in fact, the knee is a much more complex joint in so much that it twists and it also rolls back in a certain way. So we have to get the balancing of the soft tissues around the knee and all the muscles and ligaments and tendons into balance. Okay, the dramatic bit you see, or people see on the X-ray, is what we actually do. Okay, which is the bony bit, which is essentially a tibial base plate and component with a high dense polyethylene in the middle of it, which sort of replicates the meniscus, this blue shock absorber in the body, which by this stage would have probably been completely worn out, as the cartilage would have been. And this basically slots down the middle of the tibia, of the shin bone. Okay, so we get that one into there. Okay, so imagine that goes down into there. And then with the femoral component, we do a series of cuts around, and this then ends up going onto there. Okay, now there are various sizes depending on, how big you are. So this most likely is a knee replacement.
So those are big size, small size?
Yeah, this is probably more for a man, I would say. Mm-hmm. So you and I will have a very different knee. Okay, so you will have a much smaller size than probably most likely than I would. Okay, so there are various components, and that's why the inventory within the theatre is quite extensive. And you match up the sizes with various jigs in theatre.
And how long does somebody has to have that on?
Well,
for the rest of their life?
You have, that's it. There's no going back once we do that. So that's why the decision to do this, yes, the decision to put this in is not taken lightly. Okay, and that's why it is always incumbent on any good surgeon to exhaust all the conservative therapies first. Some patients come to me very late. They've got bone-on-bone change. They're waking at night. They're in severe difficulty. Just for example, they can't get maybe even half a lap round and more, and they're in their mid-50s. Not acceptable at that age. They want to stay active. In that case, almost on that first visit, they will come to me and I will list them for knee replacement. However, most of my patients are not at that late stage. And as I said, we will then pursue the more conservative options: weight loss, anti-inflammatories, physiotherapy, quadriceps strengthening, essentially. The quadriceps essentially work like the suspension in the car. If you have good, strong muscles above your knee joint, it will mitigate some of the wear and tear within the knee joint itself. Okay? So you can almost solve this yourself with good exercise. And bearing in mind, these joint replacements have only been relatively recent. These are not 100 years old. The first hip replacement, as we know it, was invented in England, actually, in 1962. So it's relatively recent. And the knee replacement came in later in that decade, about 69. Okay, so you're talking about things that have only been in 50 to 60 years. Okay, prior to that, people did probably get worn out knees and they just had to cope, or they probably had strong muscles around.
Yeah, doctor, speaking of weight, these things are very heavy.
Yes.
How do the patients cope?
The body has a great
I can imagine I'm coming to see you with, let's say, 55 kilos, and then when after the surgery, I'm at 56, 57 kilos overnight. It's
funny because an orthopaedic surgeon never thinks about that, but it's true. I get a lot of people concerned about that sort of thing. I think the thing is, Esther, that once you're in pain, you're just happy to get rid of that pain, okay? And then you want to just get moving again and just get strong again. And actually the body absorbs that the same way, a person of 120 kilos doesn't really feel his weight compared to an 80 kilo person. I think that essentially these work because patients, it gets them out of pain.
Yeah, but with this, can somebody go back to doing the kind of exercises they were doing?
Yeah.
Here we're talking about somebody who exercises maybe, a pro athlete.
A pro
athlete, yeah.
Well, I mean, look at Andy Murray. I mean, Andy Murray was a very good example. He's, obviously a high-level sports tennis player, won Wimbledon and American Open, and he's got a hip resurfacing within his hip. Okay, that whether he had a hip resurfacing or not, that's very controversial in my world now because they've actually been a little bit problematic, and there's a lot of debate about that. So he sort of set the debate forward or back depending on which side of the line you sit on that. But I mean, he's certainly still at the top of his game. I don't think he's quite winning the championships anymore, but he's still in the Open and he's still doing Wimbledon and things. So yeah, particularly with hips,
they're not a setback.
Then, no,
Just
particularly with the
quickly.
hips, I find. I mean, the hips are, most people are much more satisfied with hips. I mean, you could do a hip replacement and almost within 6 weeks, most patients will say they don't even notice it's in. Okay,
Wow.
it's that good. If there's one operation you're going to have it in your life, in all operations with all specialities, it most likely would be a hip replacement. There's a reason why it was voted the operation of the 20th century. Okay, we used to think cataracts was pretty good. You know, they're almost something for nothing. You don't get too many downsides with a good cataract, but actually hip replacements are probably better from that point of view. Now with the knees, it's not quite the same story. I get mostly satisfied patients, but just occasionally people feel like it's a bit more mechanical. There may be a little bit of numbness around. You know, it just isn't quite the same as the hip. And we don't really understand that. But as I said, we think that the knee is an infinitely more complex joint than the hip.
Now, we arrive at the path of recovery.
Yes.
So we have recovery and we have enhanced recovery.
Yes.
What's the difference?
Okay. So it's really just a concept that's been relatively borne out recently. It's about the patient journey, okay, from every stage, okay, the time you come into clinic through to the very end. We only want happy patients at the end, okay, and people started looking at every stage of that. That includes the first time you come and see the surgeon or any medical professional. You educate the patient, okay. You start telling them that on the day zero, the day of your operation, you will get up within a few hours of your operation. Now, I think that's become more accepted, especially since I've been a consultant for the last 10 years. But initially, that was not well accepted, even amongst nursing staff, even amongst anesthesia, and certainly the patients themselves. They always had the impression that they would be in bed maybe 2-3 days, and then they would get up gradually, and maybe they'd be in hospital maybe a week. 30 years ago, it could have been 2 weeks. Okay, well, you know, so we've sort of pushed the envelope in terms of that. So the patient's education is the first thing. And the first thing I tell patients is we need to optimize yourself. Okay, you can help us help you. Okay, in terms of eat healthy, quit smoking, you know, the usual stuff. Lose some weight. This makes it easy for you to mobilize. It also makes the surgery a little bit easier. Yeah, and stay active in the meantime. Okay, so I get patients asking me that a lot. Do I kind of rest and would I do any more damage? You're not going to do any more damage at this stage. The knee is already worn out. Okay.
Yeah, so, but that doesn't cause any inflammation and interfere with the surgical
not
procedure?
necessarily. It may cause a little bit more pain and trouble, and you'll obviously have to limit your exercise, to your pain threshold. But essentially, we want good and active patients. Okay. I want to see patients mobilizing as much as they can preoperatively, so that their post-op recovery is better, okay? And in fact, in certain countries, like in the UK, they will do what's called a prehab school. So you'd be with a bunch of people, okay? And you'd have a physio sitting at the top of, say, a gym, and they'd be going through exercises before you get the operation.
Wow.
So that is a dual effect, not only of like stimulating your muscles and getting you kind of ready for the procedure, but then you understand what's needed for you after the event, okay? Now, it's a very difficult area, but once you lose your mobility, it can be very tricky to get it back. So, for example, when I see patients coming because the family have pushed, them with a wheelchair, I want to know how long they've been in a wheelchair for, because I'm not sure I'm going to do them that much good, even if they have full arthritis in their knees, because essentially it's a load-bearing joint. So I'm going to be subjecting usually this old person to quite a considerable amount of surgical stress and pain unnecessarily, unless they are mobilizing.
So there are some cases which you cannot take
I'm
because
afraid
of ethical
so.
reasons.
Yeah, I'm afraid that is the case, that we just have to screen that out. Now, sometimes I look at the patients and they say, and maybe it's usually the family who are quite keen to push this, and I say, okay, show me if they can come to my next clinic after maybe 6 to 8 weeks, go with and work with a physio and start mobilizing the patient, okay? And see what you can get from them. And now, if they can get from, say, like the corridor, even on a frame, to my office, then that's good, And it also says to me that patient is willing and keen to go through this, okay? Otherwise, we might have to do other things just to mitigate the pain of this patient. Okay, so pre-op education is key. Optimizing the patient within themselves and also in the pre-assessment clinic. So you go maybe need to see a cardiologist, check your heart and all that sort of stuff. Okay. And then prior to coming into the operation, we might think about some medications either to take the pain away or just to relieve the stress. But that's usually on the day of the surgery. So this idea of preoperative medicine, pre-meds, which were a little bit out of fashion, but we kind of brought them back in again to kind of mitigate some of the kind of things that the patient will be going through. The pain relief of this operation is key to it. And I think if there's one innovation that the surgeons have got into since this operation has been about, is us surgeons getting more involved with the pain relief. Okay, so we ask the anaesthetist now, and the anaesthetists are very good. If you get good anaesthetists now, they will do what's a spinal anaesthetic. They won't knock you out with a full general anaesthetic. Okay, they essentially put you, numb the lower limbs. You can be knocked out a little bit if you want, but we try and, the idea being that the less anaesthetic you have going through you, the better it is for your rehabilitation afterwards. So you're still out of pain, through the procedure, but you are able to mobilize within a few hours of your procedure, given the anesthesia.
Let me get this straight. During the procedure, the patient can still feel something?
No, he can't feel anything because they've got a spinal in there, Not a full knockout general anesthesia, which is in the past. Not a heavy load of morphine type tablets that are going to knock you out completely and make you feel sick and, on a bed for a few days. So we try and minimize the amount of opiates, the amount of morphine, and we try and use what's called a spinal anesthetic. And plus with that, we use a high volume of local anesthetic. So you remember the little kind of bump you had on the hand, you use a bit of local. We use a big volume of that. You might have used like 8 or 10 mils to get, take that little bump off. We use somewhere in the order of about 150 mils in and around the knee or the hip as a way of alleviating the pain. Once they come through the procedure, and once that spinal anesthetic wears off within a few hours, you then have a cocktail of medications that have been sort of optimized, and various units have their own preferences, but they're all basically optimized to get the pain down. Now, some patients, particularly with the hips, they need very little. So that allows them to get up quick and start moving within a few hours. Some patients vary and they might need a little bit more. So they then are in control of that pain. So they might say, well, and if you've got a physiotherapist about to come and get you up from bed, maybe you take a few little tablets before you start your mobilizing. The other thing that's really important to note is that we minimize the other things around the actual operation. So these days, we don't usually put a catheter in that would restrict your mobility. We would minimize the number of lines you have going through and the amount of fluid you have going through. Once we can get you onto oral medications and back onto food, it would stop making you feel less of a patient. And just anecdotally, we might just say to the patient on day one, the day after the operation, maybe go in your normal clothes. Put a pair of shorts on and a t-shirt and start feeling less like a patient and more like the human being that we were treating. It has a massive effect psychologically on just getting patients up and moving again. So these are all little things. They're not massive, things. This isn't like trying to go to Mars or anything. It's all the things around the procedure. We've noticed as we get better at these things, we don't need any transfusions or very little. I virtually never need a transfusion on a primary joint these days. In the past, we had to book two units of blood as a routine, and we probably might have used them like 20 years ago. So the surgery's become a lot slicker. We know how to put these things in better. Have the implants improved? Almost certainly, but some of the long-term studies we won't know for some years because some of them are relatively new on the market. But they haven't changed dramatically over the 50 or 60 years in terms of what we can do around the patient, these very simple measures. There's certainly been some innovations in design, no question about it, but the stuff around it, as I said, the analgesia, the pain relief, the minimizing the blood products, the patient education, this is all key to it, and getting the patients up. Now, just to make a really important point with this, it's a team approach, So including the ward clerk and the cleaners, because they might just tell the patient, maybe they're a bit reluctant to get up, or we'll leave you another day. And that just blows the whole thing out, So the patient, so everyone has a role to play in this, and the families are the best as well, because you've got to get the families on board as well. So you tell them.
So usually how many days after the surgery is the patient supposed to stay in the hospital?
So we usually, these days, they're usually bored and want to go home within 48 hours.
Wow.
Okay? So, but I would say that most, with the hips, especially a young hip, say a young, fit, mid-50s guy, fit and healthy, he's usually going home the next day, almost certainly. Okay? Now, can we do a same day? Almost certainly we can. We got to get the right patient, and he has to be sort of prepared on the day to bounce it maybe for the night. Okay? So it would probably help to have some nurse on call who can just reassure, give the medications, all that sort of stuff. But that's certainly coming. And that certainly will be the routine and the norm in the next phase. Okay? And we are kind of heading towards that as well. If a patient wants to come and do it on the same day, I'm more than happy to do that, particularly with the hips. Okay?
So currently, do we have that here at King's?
Not a service as such, okay? But I would say that any patient who feels that they want that to be done, we can certainly accommodate that. Okay, so we would get, and also accommodate the fact that if it doesn't go right on the day, or it's not, the pain isn't quite as well controlled as we want, then he's prepared to stay just for the overnight. Okay, and actually, as I was discussing earlier, Esther, sometimes patients want to stay anyway. The hospital is nice. It's like a hotel. They've got all these nurses doing stuff for them. You know, poor wife's probably got, the in-laws staying, and that's usually some other factor, and she needs a night off as well. Okay, so, you don't want to burden, the family as well if they, and they've got a flat screen all to themselves with a TV remote, so staying in hospital is actually quite nice. We're not in governmental hospitals where, and they have these private rooms and all that stuff and quite nice food and everyone makes a fuss, so,
so they just feel good.
Yeah, exactly.
To stay here.
It's tricky to get patients home when it's like that, It's like saying, well, you booked a hotel, but you're not going to stay in it tonight. You're going to go to the hostel down the road. No, it's not going to happen.
Yeah. Sure. Doctor, thank you. It was a pleasure having you here.
Thank you very much.
To book a consultation with Dr. Paul Macnamara, just call 04-247-7777 or to know more about the Enhanced Recovery Program after hip and knee replacement. Until next time, bye-bye.